Our next talk will be presented by Dr. Yeat Choi Ling, Palliative Medicine Consultant and Head of Palliative Care Unit in Hospital Raja Permaisuri Bainun, Ipoh. She is extremely interested in complex cancer pain and breathlessness management. At the national level, she has been a key person in mapping palliative care services for all public hospitals across the country. Dr. Yeat will be talking about total dyspnea management. Welcome, Dr. Yeat, on stage.
Good morning, ladies and gentlemen. First of all, I would like to thank the organizing committee for inviting me to give a lecture on total dyspnea management. In this lecture, I try to cover the definition, prevalence, and experience of dyspnea, assessment of dyspnea, both pharmacological and non-pharmacological management of dyspnea. At the same time, I would like to share with you our experience of running breathlessness supportive therapy clinic in Ipoh. What is dyspnea? Dyspnea is a subjective experience of breathing discomfort. It is a multidimensional symptom which is affected by physiological, psychological, spiritual, and also environmental factors. Prevalence of dyspnea is high among palliative care populations. Among the general cancer populations, the prevalence range from 10 to 70%. As the patient coming near to the end of their life, the prevalence of dyspnea increased significantly to 70% in the last 6 weeks of life. Incidence of dyspnea is not low, it's rather high in advanced non-malignant diseases. For example, COPD, it is very high, up to 95%. It is also quite high among patients with advanced heart disease, AIDS patients, and also renal failure patients. The experience of dyspnea is very variable from a person to another person. No matter how they describe the experience that they had in the past, it's usually very complex, very frightening. Almost all the patients were fearful of the last breath. Assessment of dyspnea should include at least these 3 aspects. Ask the patient to describe their experience of breathlessness. When you ask the patient to tell me about your breathlessness experience, so the patient will give you information like the onset, offset, the chronicity of dyspnea, the severity, the emotion part, and how distressing it was. And you need to find out whether there is any trigger factors that actually trigger the dyspnea episode, whether there is any reversible causes, anything that can make it worse, or anything that actually can make it better. And as you explore, you will find out the impact of breathlessness on patients' activity of daily living, as well as the relationship with their loved ones. Causes of dyspnea could be due to the disease itself. Here, I would like to use cancer as an example. It could be due to cancer infiltrates, cancer's complications like pleural pericardial effusion, airway obstructions, ascites, anemia, muscle weakness because of cachexia. It could be due to infections of pulmonary embolism. It could be due to treatment, for example, post-pneumonectomy, drugs. Sometimes certain drugs can cause bronchospasm. And do not forget, dyspnea also can be caused by the comorbidities, for example, fluid overload in renal failure and heart failure, as well as bronchospasm in COPD patients. I would like to share with you a multidimensional approach to managing dyspnea. I will use my patient as example in managing dyspnea. I have a patient, he is Mr. A, 48 years old, he was arts teacher. When we saw him, he was newly diagnosed to have non-small cell lung cancer. Unfortunately, it was inoperable upon diagnosis, and he wasn't fit for chemotherapy as well. The disease progressed rapidly with increasing breathlessness over 1 month durations. When we saw him, he was still pink, but he was very tachypneic with the respiratory rate of 36 per minute, and he was hypoxemic with the oxygen level 87%. X-ray showed tumor infiltrates. Social history-wise, he was married with 2 kids. Both are very young, 15 and 8. The wife was the main carer. We started morphine for him, 2 mg for hourly, titrated up, then converted to sustained release morphine. And we also started dexamethasone in view of lung infiltrates. His SpO2 oxygen level improved with oxygen therapy and with the treatment that we had given to him. And his respiratory rate also reduced to 16 per minute. However, he was still breathless. He was still confined to bed, totally in the bed, and not able to self-care. When we say that we probably have to discharge you soon, we saw his face turn full of worries, full of fear. We found out something, according to the nurses in the ward. Mr. A kept looking at the oxygen tank. Actually, it's not the oxygen tank, it's the signal here. Okay, this is the signal with the arrow indicator. He will watch when the arrow points to this yellow line. He will call the nurses, please change a new tank for me, please. He was very, very worried, very anxious that he would not have enough oxygen supply. What did we do? We sit down and listen. Listen to his experience of breathlessness. And we found out he has a lot of psychological issues. He was very anxious because he had suffocating experience when he had breathlessness attacks in the past. He would not want to have this experience anymore. And he was very worried. In the hospital, we have nurses, we have so many oxygen tanks. But when he goes back home, there is only one oxygen concentrator, which actually requires electrical supply all the time. He was worried if there is any electrical supply cut off, he will be lack of oxygen and he would die of suffocation again. And also another issue, lack of support at home. He had a lovely wife. The wife was very good, but the wife was exhausted. She has to take care of the house, take care of him, take care of the 2 young kids. And in view of increasing needs of care, nursing care for him, the wife would not be able to cope anymore. Financial issue is a problem. He was the only breadwinner in the family. And spiritually, luckily, there was no major issue. He told us he was well prepared for death, but he just couldn't and he wouldn't want to have that suffocation, that feeling anymore before he died. He already actually made arrangement with his family, okay, about the arrangement after he passed on. He was then referred to occupational therapists for breathing and relaxation techniques. And we started lorazepam for him, started inhale fan, and also we discussed with him about his dyspnea plan. With that, he started to move around his bed, okay? And this is the day when he was discharged. We managed to bring him out. This is outside the ward, okay? And he was in the wheelchair without oxygen supply. We spent about 20 minutes outside. And what was he doing? He was drawing a sketch, the view in front of him. Okay? What worked well for him? I believe it is the relaxation techniques and the dyspnea plan. So we educated him what to do when he has next dyspnea attack. It will not go off totally. It will come again, but at least he can do something. So he was happy with the dyspnea plan. It makes him to feel that he has some control over such a frightening, difficult situation. And lorazepam worked. Non-pharmacological management of dyspnea. I would like to share with you the experience of us in Ipoh providing breathlessness supportive therapy to our patients. It is an occupational therapist lead project. So based on the concept, breathing, functioning, and thinking are all interrelated. Based on this model, we go on and teach our patients breathing. We found that this is very useful, this breathing technique. That is called recovery breathing. It involves 3F, okay, forward position, okay, then focus on breathing out. So we teach patients the right position, okay, which actually consume this energy. And we also showed our patients the handheld fan, okay, so we help them to buy as well. So we teach them to blow towards their cheek or towards their nose. Focus on breathing out. We tell them when you are breathless, okay, beside position yourself on the fan so you can focus on any rectangular shape object. For example, the window, okay, or the door. So breathe in, follow the short line. Breathe out, follow the long line. Breathe in, short line, breathe out, long line. Focus until they feel better. I found this is very useful and patients agree with that. Second, manage their thoughts. It's a form of psychoeducation to manage fears and negative thoughts associated with breathlessness. It helps to reduce anxiety. So we try to correct the misconceptions about being breathless, like I'm going to collapse, I need more oxygen, I'm going to have heart attack. Instead of thinking all these negative things, so we try to ask them to think positively, okay, help them to calm down. So I have this before. Now I have a dyspnea plan, so I know what to do. So I will lean forward, I will use my fan, okay, I will focus on breathing out. Take my lorazepam, I can take my morphine. Okay. So we also teach relaxation techniques. One of the things my occupational therapist taught was progressive muscular relaxation for patients who is still very fit. Okay, imagery. Some of the patients like aromatherapy. So it depends, it should be individual. And the third part is functioning. We tell our patient, try to keep yourself active if possible. Okay, it's a form of pulmonary rehab. Continue to exercise. It's very useful for patients who are relatively fit, like those chronic COPD patients. And this is very useful. I found this. And managing your energy level. You know, you have so much energy, so you need to prioritize. You need to plan. Okay, what is most important, you do first. Okay, and pacing is very powerful. You need to take breaks in between. Okay, slow down, do one thing at a time. So from November last year until October this year, we have total of 29 referrals. 66%, 19 attended our clinic. and 79% completed 2 sessions, and 21% completed 1 session. So 34% of default rate. So it is mainly because of patients was unwell, patient passed away. So it was very encouraging. So our patient scores actually our service between 7 to 10, and 77% give us score of 9 or 10. We will continue this service. Okay, so and I would like to show you another patient of mine who is Mr. ZA, 75 years old, a retired horse trainer. He was referred to us for management, co-management, okay, with the chest team for breathlessness. He has advanced COPD. So he had frequent admission every time for his COPD exacerbation. He stayed about 2 weeks in the ward. But we were surprised to find out that for each clinic review, he actually cycled to our clinic from his home. He left his home early in the morning, stopped 2-3 times actually for a 5-kilometer journey. We introduced aqueous morphine to him prior to major exertion, and he continued to cycle every day. He used morphine as needed, then continued his journey again. This is Mr. Z. Okay, during our pet therapy, he was on the horse. He was very happy. So what worked well for him, I think, is the self-directed pulmonary rehabilitation. And he was a good planner. He knew how to conserve his energy. Okay, and morphine works for him. COPD treatment works for him. Pharmacological management involves opioids, mainly systemic therapy. So morphine is safe and effective to be used for dyspnea management. Okay, so if patient is not able to tolerate morphine, for example, patient can't swallow, fentanyl is another alternative. Benzodiazepine is very helpful, especially if the patient has anxiety or panic attacks. So normally we use lorazepam, alprazolam, subcutaneous midazolam if the patient is no longer able to tolerate orally. What about oxygen therapy? We don't use for every patient because evidence show that it's only beneficial if the patient is hypothermic. Okay? Please do not start oxygen for all patients with breathlessness. Okay? It shouldn't be a routine. Do not increase burden for patients. Okay? So the summary for today's lecture is management of dyspnea starts with a comprehensive total dyspnea assessment. You need to know multiple aspects, that the factors that contribute to dyspnea experience, including physical, psychological, social, and spiritual. With that, you can give your patient total dyspnea management, which include both pharmacological and also non-pharmacological approaches. Thank you for your attention.
Thank you very much, Dr. Yeat. I think that's a very important subject that we need to talk about because dyspnea and pain are definitely the two most common symptoms that we face in palliative care setting. We'll move on to the next session afterwards, but please I encourage the audience to ask questions either on the message box or on the Q&A tab during the talk. We'll address them during the Q&A after the 3 lectures.